angle closure glaucoma. So as you know, when the optic disc and the visual field changes are present, then you call it a glaucoma. Now what is this angle closure glaucoma? The angle is closed. When we talk angle, what are we worried about? We're worried about the angle through which the aqueous flow in the eyes takes place. You need the drainage of the aqueous flow. Now, if you see the healthy eye on the picture of your left, you can see that the arrow marks demarcating the flow of the fluid, the aqueous humor basically, from the posterior chamber to the anterior chamber. Now, when you come to the closed angle glaucoma, you can see that the iris is not in its position. It is bent. It is touching the lens. It's touching the pupillary margin. And what's happening? There's a block, like there's a gate. That gate has been closed. Now, when the gate is closed, there's no way for this fluid, this aqueous humor, to flow from the posterior chamber to the anterior chamber, and hence you have acute angle closure glaucoma. You all might wonder, what is glaucoma? What is angle closure? What angle is getting closed? Why is it a problem? Why do patients develop because of this? Yes, you all have answers in this slide for that. Now, first picture, as you see, you have the iris, you have the lens, and you have the pupil where you have a teeniest gap between them. But if you see in picture B and picture C, there's no such gap. Why do you need that gap? You know that the space before the lens and behind the lens is the anterior and the posterior chamber respectively, and you know something called aqueous humor is present, which moves from the posterior chamber into the anterior chamber, and then it drains out. But in our condition, glaucoma, this is not happening, and that's why the pressure is causing a lot of problems. In the first thing, as the arrow suggests, from the posterior chamber, the aqueous humor freely flows into the anterior chamber, no problem. Coming to picture 2. The space that has to be maintained between the lens and the iris is closed. It is touching the lens, and the pupil margins are also touching the lens, where there actually has to be a space. What is happening because of that? It's like a barricade. It's like a barricade for the water, and when you put the lids on, what happens? The water doesn't flow. It gets accumulated, and the same thing happens in B. You can see that the arrows are going till the iris, but it cannot go to the anterior chamber because the iris is touching the pupillary margin and hence the lens, and that is the gate. Now coming to section 3, but before that, in section B, you can see that in the periphery, the space between the iris, the trabecular meshwork, and the cornea, there's a space. But can you see that in picture C? No. Because of the pressure that is exerted by the fluid, the iris has moved forward. It has bent, and that is called iris bombae. That is, the peripheral flaccid iris is pushed anteriorly because of the aqueous humor that is collected behind. So, you know that when there's a hose pipe in your house and then you shut the opposite valve through which the water has to come out, what happens? There's a lot of pressure exerted on your hands that you are forced to take your hands off. If your hands are not taken off, at least you will actually bend it. Same thing happens to the iris. The iris bends, it goes forward, and that phenomenon is called iris bombae. Coming to the last picture, you can also see in the periphery that the iris, the trabecular meshwork, and the cornea has come into contact with each other, because of which we call it as iridocorneal contact or iridotrabecular corneal contact. Now, what happens if it's been in contact for a very, very, very long time? You know, when two things are in contact with a very long time, it starts forming adhesions. Fibrosis, adhesions happens. And when adhesion happens, we call it a sign K. And because it is in the peripheral part, we call it peripheral anterior sign K. It's in the peripheral part, so peripheral. It's in the anterior chamber, so anterior. It's forming adhesions, which adhesions means permanent. You have to do surgical treatment, of course, because when it's in a stage where, if you see the picture B, only the pupillary margin is being closed. There is space in the periphery, but when you come and see the picture C, the peripheral space is also closed. So this is called peripheral anterior sign K. And this is how your glaucoma eyes is going to suffer. The pressure is going to be raised because it cannot flow, it is obstructed. There's a gate, and the gate is the iris, so it gets accumulated in the posterior chamber. Moving on, angle closure glaucoma is not an overnight phenomenon. We know that everything has its own process and takes its own time. Now, with the time of formation, with the time of progress, here you have the classification, which makes it very easier and simpler for us to understand. Yes, you have three types of the classification is of three types. Number 1, primary angle closure suspect. Number 2, primary angle closure. And number 3, primary angle closure glaucoma. Now, what happens in this primary angle closure suspect? Your intraocular pressure is normal. Your optic disc is normal. You check for the visual fields, that is also normal. But why do you suspect? It is because the gonioscopy has revealed that the iridotrabecular contact is greater than 270-degree angle and there is no peripheral anterior synechiae. Now explaining you what is peripheral anterior synechiae is, if you see the figure 3, there you can see that the iris, the cornea and the trabecular meshwork has come in contact with each other. Now all of them come in contact with each other. That's when I told you it is iridotrabecular contact. But when do you call it a synechiae? When two things are in contact for a long period of time, what happens? Adhesions, and this adhesions is called synechiae. Now here if you see in the corner, adhesions have formed and that is in the periphery of this eye, and so you call it as periphery anterior synechiae. Periphery because in the periphery, anterior because it is in the anterior chamber, and synechiae because it is formed permanent adhesions. Moving on, the second type, primary angle closure. Now what has happened here? Again, the optic disc is normal, the visual fields are normal, the iridotrabecular contact is greater than 270 degrees of angle, but the intraocular pressure, which was previously normal in the suspect, has been elevated, and the peripheral anterior synechiae, which was not present in the suspect, has been developed. Now the third part of the classification, which is primary angle closure glaucoma, here the intraocular pressure is high, it's constantly raised. The optic disc now shows glaucomatous cupping. The visual fields are also seen. There are defects present in the visual field which was not previously seen in both the types, and the gonioscopy is revealing more than 270 degree of angle closure along with peripheral anterior synechiae. Apart from the classification, you have something called absolute primary angle closure glaucoma. What is it, absolute? When the primary angle closure glaucoma, that is the final stage, in the classification, the third part, if it is left untreated, it gradually passes into the final phase that is called absolute glaucoma. Till now we've seen what is angle closure glaucoma. We see how it is getting developed from a healthy eye to a glaucomatous eye. Its classification, that is basically the classification is the stages of how it is happening. And now we're going to see the risk factors, like who are all the risk category of developing this glaucoma. First is females. Why do I say females? Because females normally have a smaller eyes and a smaller axial length, which is itself a risk factor for developing glaucoma. Similar to hypometropia also, when you develop hypometropia, your axial length of the eyes reduces, and hence again a risk factor. Shallow anterior chamber. What happens when your axial length of your eye reduces? You get a shallow anterior chamber and a small cornea. How is small cornea predisposing factor? Because smaller the cornea, the radius will be small. But what happens to the curvature? The curvature is very high. So the smaller the cornea, the more the curvature, the more the risk factor. Now coming to plateau iris. So plateau iris is basically your iris has a tiny angle, but here it has a very flat appearance. So plateau iris, what this plateau iris predisposes to, it has high chances to attach to the pupillary margin and also the lens, blocking the aqueous flow. Now these are the risk factors. Females, hypermetropia, shallow anterior chamber, small cornea, and plateau iris. Now, after knowing who would develop this, your next question will be, how will I identify if any of my family members or somebody coming to the OP is having glaucoma? Meaning the presenting symptoms. What would they be presenting symptoms? If you see the first picture in the left upper corner at approximately 11 o'clock position, you can see that a dim image. What does it say? Dimness of vision. Second, pain in your eyes. Third, severe headache. You have vomiting, you have redness of the eyes, and most important, colored halos. Colored halos means there's a white light, and around the white light you see the Vibgyor color, that is the rainbow color. So why is it happening? Ask yourself. Signs. Here's where we doctors, our role starts. First, what you have to do, you have to check the intraocular pressure. If the intraocular pressure is more than 40 and severe pain in the eye, you have to suspect glaucoma. And how do you do it? It's very easy. You can still do it with a digital tonometry where, the 2-finger procedure, you press it on the eyelids and then you find a rock hard eye. Please proceed forward. Second, on torchlight, you can see something called eclipse sign. Why do you see eclipse sign? What it is telling you? It is telling you that the anterior chamber is shallow, because of which when you shine torch on one side of the eyes, the light is only on one side of the eye, and on the other side the shadow falls. Just like during the eclipse day that the sun is not shown, that just its shadow is being seen. Similar to that, when the light is shone on one side, only the shadow falls on the other side. The light does not travel to the other side, and that's called eclipse sign, and you see it in shallow anterior chamber. Moving on, you see congestion or hyperemia. What is hyperemia? It's nothing but redness of eyes. When we tell the signs, we have to elicit in medical terms. So that's why we don't say it as redness of the eyes. We say it as hyperemia. Then hazy cornea. Your cornea is not going to be clear. You're going to see something very cloudy. You're going to see like a broken egg. So that is hazy cornea, or also corneal edema. What is this hazy cornea and corneal edema disposing to? Hazy cornea is causing diminution of vision, and corneal edema is causing colored halos around the light. Now, as I've told you to think before that, why do you think there is colored halos around the light? Now I'm going to tell you the answer. The colored halos around the light is due to the prismatic dispersion of the light rays. Because you have water accumulated. What happens when a water droplet is on a leaf? You beautifully see the dewdrops, and the sunlight falls on it. You see the Vibgyor colors. Or on a rainy day, when the sunlight falls on the rain droplet, that's when you see a rainbow in the sky. Similarly, your aqueous humor is not draining. There is aqueous humor accumulation. So what happens when you look at a white light? This aqueous humor inside your eyes are dispersing these light rays, hence forming colored halos. The fourth sign is iris atrophy. Now, you're being pressed under a building. For example, an earthquake, and then you fall off, and then there's a big building that has been on your arms or on your body. What happens to that area? There's no blood supply. Necrosis happens. Because of the pressure, you have to amputate that limb. Similarly, I told you that the accumulated fluid is exerting a lot of pressure on the iris. So, there is iris atrophy happening now. Next is posterior synechiae. I've told you about anterior synechiae. Now you're saying, Ammu, what is this? You're saying posterior synechiae. Posterior synechiae means the adhesion between the pupillary margin and the anterior surface of the lens. When the iris bent, I told you that there is adhesion between the cornea and the iris. But something happening in the middle also. The other end of the iris is touching the pupillary margin and the lens. So there has to be adhesion there also, no? Why is that not happening? No, that's happening, and that's why posterior synechiae is present. So synechiae means I told adhesions, and because it's on the posterior parts of the iris, it's called adhesion between the pupillary margin and the anterior surface of the lens. Next is cataract. Yes, cataract, also known as glaucomflecken, glaucomflecken, which is anterior capsular or subcapsular opacities. That is due to the epithelial ischemia and necrosis in the lens, in the anterior capsule, and hence you can again suspect glaucoma. The last is pupil. The pupil is mid-dilated and fixed. That is, the pupil can neither dilate, can neither constrict of what it is now. It has become vertically oval and the pupil is in danger. But in open angle glaucoma, there's no problem to the pupil. The pupil is normal. So when your examiner asks what happens to the pupil, or when the question in your exam comes like what happens to the pupil, then you can just close your eyes and think this is a question about angle closure glaucoma, because in open angle glaucoma, the pupil is normal. Now, summing up all the signs, we have something called as Voigt's triad. What's this Voigt's triad? Iris atrophy, as I have told you, because of increased pressure, the iris atrophies. The glaucoma flecken, because of the cataract, the subcapsular opacities. And fixed mid-dilated pupil. All this together forms the triad called the Voigt's triad. Now, summing up the signs, hyperemia, which is also called the redness of the eyes. You have a hazy cornea, the corneal edema, hazy cornea leading to dimness in the vision, corneal edema leading to colored halos, iris atrophy, posterior synechiae, which is because the other part of the iris is touching the pupillary margin and the lens, which is forming adhesions again. That's called posterior synechiae, glaucoma flecken, and mid-dilated fixed pupil. And I told you that this iris atrophy, glaucoma flecken, and mid-dilated fixed pupil, all these three together is called the Voigt's triad. That is number 3, number 4, and number 6 signs are together called Voigt's triad. Coming to the treatment part, we have to treat according to the classification both the primary angle closure and the primary angle closure glaucoma. If it is the stage of primary angle closure, our immediate step is to reduce the intraocular pressure to prevent the further damage. So what do? You give IV mannitol. So IV mannitol is an emergency, is a drug of choice to reduce the intraocular pressure. And if you find the intraocular pressure is more than 40 mmHg, you have to close your eyes and administer IV mannitol 1 gram per kg body weight. Then for pupillary constriction, you administer pilocarpine 2% and it should be started after 1 hour of the commencement of the treatment. That is, when the IOP is lowered, as such higher IOP sphincter is ischemic and unresponsive to pilocarpine. So you have to remember this, and only after you administer mannitol and reduce the intraocular pressure, you're supposed to give pilocarpine. Or if you initially start with pilocarpine, you are causing further damage to the eyes. Now what I told you is the immediate medical therapy. If you ask me, Amo, what is the definite therapy? Then it is laser peripheral iridotomy. You make a cut. It's basically you take a scissor and then you make a cut. But the cut has to be between 11 o'clock and 1 o'clock position. That is the most preferred site. 11 o'clock and 1 o'clock means it's somewhere around the top of your eyes. You know that it's always the 2/5 of your iris is being covered with your upper eyelid. So when you make a cut there, aesthetically also it looks good. It's not like when people see they're like, hey, there's a hole in your eye. They're not going to say that. So that's why 11 o'clock to 1 o'clock is a preferred position, and laser peripheral iridotomy is the treatment of choice. But if it has progressed to primary angle closure glaucoma, then you have to do laser iridotomy alone or along with the medical treatment that I've told before. But laser iridotomy has to be done. If that fails, we can do trabeculotomy. Or tomy means cutting. So we're cutting the trabecular meshwork. So it is basically a filtration surgery, and that is done only if the treatment fails to control the IOP. Finishing off, this is the summary of angle closure glaucoma. The classification, the symptoms, the risk factors, the signs, and the treatment. Thank you all. Thank you for watching. It's a bye from Ammu from Med School.